in our hemodynamics class with all of you guys, invasive, vascular, and echo. And then for the, so we kind of applied some things to that with the 3 ways of measuring cardiac output. This is going to be more about how your body uses cardiac output. And there's 2 kind of main concepts we'll be talking about. One's called cardiac function curve, which is really Starling's law. And then in this chapter, there's something called the vascular function curve, which has to do with where does the vascular volume move to at low and high output states. So those are pretty new concepts we haven't really talked about too much that we'll hit today. And then Wes Todd, Wes would teach these classes with me over the years, and this was one of the chapters he always taught. So he kind of wrote this. I've adapted. He added something more that then was in the book. He added heart failure. You know, the book talked a little bit about heart failure, but Wes, in the back 2/3 of this presentation, has a whole section on heart failure. And we kind of look at it from 8 perspectives. You guys know what I'm talking about from your previews? Have you ever thought of it that way? You know, I kind of talked about left heart failure and right heart failure in hemodynamics, didn't I? But this one kind of breaks it down into left and right, forward and reverse, acute and chronic, systolic and diastolic. And Dr. Limegrove talked a little bit about diastolic heart failure and early signs. So we've been kind of dancing around some of these things, but today we'll kind of dive into it and really break heart failure down into 8. I do hear that. The other day we heard people like, do you hear a tone? I'm like, nah, no, I have tinnitus, but that sounded like a fog horn on the ocean. That was somebody's phone vibrating, I bet. That vibration, that was that low frequency vibration. I don't know. Anyway, so sorry for getting so distracted. It's like a dog and a squirrel that just ran by. But we have been hearing strange tones in this room. Do you guys in Tacoma ever hear strange? Do you ever feel strange presences?
Yes.
I'll take the tone. I'll take our funny sounds over here. Okay, so
sometimes we'll just be sitting in the classroom and you have to use a badge to enter the classroom and it has a little clicking sound. And every once in a while you'll sit there, you'll hear the clicking sound like someone's going to come in, but nobody ever comes in.
Like maybe they did come in, you just didn't see them. So for you guys in echo and vascular, the background on that is the classroom in the Tacoma School is a cath lab that was used for several years, and I predict that that's been a transit way for many souls to pass on to the other realms, however you believe. And so there could be some energy in that room, and I kind of freak them out with that story, and it works every time.
You have to have a badge to get to the other side.
Say again?
You have to have a badge to get through to the other side.
Yeah, nowadays you have to have a mag card to get to the other side, yeah. Anyway, we'll get to it with this. So cardiac output, we're going to take a look at these things, factors that affect the vascular function for the cardiac function curve, a big look at heart failure. We've already looked at Laplace's law. We'll take a little bit of talk about how the heart and vascular system work together. What happens at really high heart rates and what really low heart rates. You can probably estimate it based on your knowledges already, but we'll look at that. Something we haven't talked too much about is venous return, how gravity affects that below and above the heart. And then what happens, how important is your muscular pump at returning venous blood? Very important. And then what happens with respiration? We've looked at that in our hemodynamics, just watching the waves of respiration, but we'll add a little twist to that. What happens if I put you on a ventilator and instead of a negative inspiration, I create a positive pressure in your lungs to make inspiration happen? What happens to your venous pressures then? So we'll look at all of that. There's a lot. Wes was busy when he wrote this. I was reading this and I was reviewing. I said, "What? That's all just for one class? For God's sakes, Wes, that could have been 2 classes worth of stuff." That's what I thought when I prepped myself. So some of this stuff we already know about, cardiac output and CHF. These are terms you know about. Afterload, I asked Dr. Limegruber to describe that. It's the things that work against our heart pumping. Contractility is the upstroke of the LV contraction, and compliance is how stretchable are the vessels. We looked at that a couple chapters ago. And then the preload we know is measured as the end diastolic pressure in the left or right ventricle, or the mean atrial pressures. Venous return is described as the flow coming back from the vena cava. It also would be the pulmonary vein venous return. But a CVP is known as the right atrial pressure, or the RVEDP, central venous pressure measured at your heart in the right heart. And then the wedge is the pressures in your left atrium or your LV at rest. The filling pressures. What is your pressure right before the heart pumps? And these are some important terms to be thinking about. Hypervolemia is just too much volume. And there's two factors that determine cardiac output, which is stroke volume times heart rate. Those are some fundamental concepts. Your heart can raise its cardiac output by increasing its stroke volume or its heart rate, but in fact, it actually does both. So you can get kind of an amplified effect by manipulating both. We learned about that in the heart rate chapter with contractility and heart rate management. And then three factors determine your stroke volume. The harder you fill the heart, the more it wants to kick, so you get a bigger stroke volume. And the more afterload you have, the more resistance to the reduced stroke volume. So reducing your afterload with nitrates, reducing vascular volume would create decreased resistance and easier for your heart to pump volume. This we learned in Dr. Limegruber's talk about the pump with his pressure volume loops. And then the contractility, which is the force of contraction, which we can manipulate with inotropic drugs like digitalis or epinephrine, norepinephrine, dopamine, dobutamine. And compliance is just the stretchability. Arteries are not as compliant. Veins are very compliant. In fact, they're 20 times more compliant. Here's a cross-sectional picture of an electron microscope picture of an artery and a vein. And you can see the media, the walls are thick in an artery. The veins do have tunica media. They do have muscular layer, but it's just pretty thin. So the veins are very stretchy and compliant. This is getting to, here we go. This is getting to one of the new concepts for this chapter. And it's kind of an important concept, just like the myogenic mechanism was pretty important last week, The more pressure, the more constriction for regulating flow. Well, this is one of the key concepts in this chapter. So I'll take my mask off to clearly say it. So this is the vascular function curve. Does anybody want to take a stab at trying to describe it to us? What did you get out of it? What does it mean to you? Further we get into the program, and especially I was thinking about you guys, the second year of the program, there's a lot more back and forth because you guys have been out in clinical and you've seen things and you've been blooded. And so you have comments. Now I saw that and this is what I think. And I know in the first years, sometimes you're more into the receive mode. And now I've given you enough time to think of an answer. I've paused and I've delayed for you. So somebody want to take a stab at explaining because you're doing this in study groups. So like, hey, what does it mean to you? So, and that's okay. It's early. You haven't fully prepped for the test because for God's sakes, it's not till Thursday. That's like days away. That's not even on your day horizon. That's down the road.
Is it just
I understand.
Is it
Go
just
ahead.
When CO decreases that the central venous pressure increases, that there's an inverse relationship?
That is it. That's it. That's it exactly. So this graph kind of shows it. So here's cardiac output at 4, which we might consider normal. And here's CVP at 4, which we would consider normal if the right atrium's 2 to 6 millimeters of mercury. Okay. So what drives this? It's not the CVP that drives it. It's the cardiac output that drives it. So there's there's 3 or 4 little like racetrack pictures of the heart and blood moving around like a little oval afterwards that will just help make sense of this. But if your cardiac output falls because you have a low cardiac performance, reduced ejection fraction, for whatever reason, you had some cardiotoxic drugs, you're having chemotherapy, and your heart's function is being diminished, it slows down, and the blood pools in the veins. And that's why the CVP rises. So when your heart, when the whole, think about your body is like, goes through the artery, goes through the vein, it's like going around a racetrack. And we'll look at this picture next. In fact, here's this picture of blood flowing through, or actually here's the one-way arrows. This is the racetrack of the flow through your vascular system. And in this case, say the pressure in the vein is 2, pressure in the artery is 102, and the flow is 5 liters a minute. And so everything's fine. Everything's rolling along. When the cardiac output starts to fall, then blood pools in the veins. And then as you start accelerating, blood moves over to the arteries where it's needed to be given to the muscles that are working and all the tissues that are working. So the blood can pool in the vein at low output. That's a reservoir. So now if I look at this, I say, okay, well, when the CO drops, the CVP rises. That's just the blood pooling in the veins. Other places in your body that are reservoirs for blood are other organs. So this is not in the book, it's just a side tangent, but where else can blood, what else does your body have for a reservoir of blood? Say you're bleeding out from a motor vehicle accident, your body's already constricted all the vasculature and pulled all the venous blood back. Somebody had the presence of mind to put your feet up and let the blood drain to your head and chest to help give you more volume, but you're running out of volume. What other organs? Where's some other blood sources that we have in our body? The liver and the lungs, yes. Those are the 2 big ones. The pancreas and your skin. Your skin has a lot of blood. So that's why when people are really sick, they look all white and pale. So the skin is all constricted and the blood is pulled out of there, back to the core. Because it's like the heart, you need a preload to have a stroke volume. If you don't fill the heart, it can't pump anything. All right, so we'll look at this model of failing. So there's everything, this is happy. There's the racetrack, everything's good. Everything's working like it should. And then here we are at the beginning of cardiac arrest. Maybe the patient has VFib or they have VTAC with a heart rate of 250. It's so fast, there's no forward flow. And right now the pressure or the flow is 0 liters a minute, but initially the pressure stays there. But now it'll run off. All this blood here in the arterial system will pour off and run off into the veins. And here she goes. See, pressure starts dropping, veins start swelling. And now this is what your pressure will look like when you're essentially dead, if we don't do CPR. This is, and I've seen this is what your pressure will be. Your systolic pressure is 7, and your venous pressure is 7. This is the natural hydrostatic pressure of your vascular system with normal volume. This normal vascular volume. So your blood pressure would be 7/7 with a mean of 7. Not enough. And 0 flow. So whatever blood's in those capillaries gets exhausted and there's no fresh to replenish. So this is what death looks like on the hemodynamic chart. So we start doing CPR. Here we go. And maybe we get the blood pressure up to 26 and we got about 1 liter. You know, when you guys had your CPR instructor class, did they tell you what percentage of cardiac output you could expect to generate with high quality CPR? They might have. 30. 20, 30, yeah, not very much. So we're just trying to keep the organs viable until we get the cardioverter to shock them back. That's what's going to save them is the electricity, not your healing hands. You can keep them, try to keep them viable, but what's going to bring the motor back is the shock. Or we can put a pump in them. We can put a big pump inside their heart and like a little miniature jet ski with a little auger, and we could start sucking blood out of their LV and pushing their aorta at 3 to 5 liters a minute. That's called the Impella pump. We might have talked about that in one of our classes. So you get them into our hands, we can keep them alive with a left ventricular assist device. But CPR alone is just trying to hold them over, trying to hold on. Okay, So here we go. Blood pressure's getting up to 26. CVP drops a little bit, not very much flow. All the blood's really pooled over in the veins. And this is just another look at the vascular function curve. So it also adds artery here. So as cardiac output falls, blood pressure falls, and the blood pools in the veins and CVP rises. So that's the vascular function curve. Low output, blood pools in the veins. High output, it gets recruited back. Here we go, higher output. And here goes the blood pressure rising in the artery. And here it is dropping in the veins. So at high output, the blood moves from the veins to the arteries. Low output, it slides back into the veins and they're compliant 20 times and they stretch. That's kind of a concept. Where's your blood? Depends on your cardiac output. Okay. Now we'll look at it instead of on this kind of a graph, we can put it on this kind of a graph. And here's the CVP, the pressure in your right atrium, and here's your cardiac output. And this is just this is the vascular function curve displayed on a graph. And we're going to look at it like this because we're going to look at a cardiac function curve next and add it to this graph. So let's just see if this CVP vascular function curve matches this. Let's translate this data over to this graph. So here's higher output up over here, and the CVP was low. So at high output, the CVP is low. So let's look over here. Here's low output, low cardiac output at 1, and the CVP is 10. So let's check that. So low output 1, CVP 6 on this graph. It's the same thing. It's just displayed in a different way, right? We put both of them on the same graph, X, Y. Instead of singular variable, it's a double variable graph. So this is the vascular function curve. It just says at high outputs, you have low CVP, and at low outputs, you have high CVP. Because why? What makes that happen? Why is that? Because of blood pools in the veins at low output. That's all this is saying. It's not complicated. Okay. Now, if I give you some volume, I give you a liter saline for the same cardiac output. Let's say here's our base example. And I gave you a liter of saline, and look what it does to your CVP. So the same output, let's say I was at 5, and now I'm at 5, but instead of being at 2 CVP, you're at 4. I gave you a liter of saline, you have more vascular volume, your CVP rises. That's a no-brainer. If you lose volume, you bleed out, then your volume drops. So at the same cardiac output, your hypovolemic state, your CVP is lower. So that's all this is saying. So this is your vascular function curve at normal state, but it can be changed if we add or take volume. We could give you a diuretic and take volume away. If you're up here in a hypervolemic state and your lungs are starting to get wet, we can give you a diuretic and bring you back down to a normal area. Okay, that's all that's saying. So that's it for the vascular function curve. Now we'll add this cardiac function curve, which is nothing new to you all. It's called Frank-Starling's law, and here's the Starling curve. Whereas if I give you more CVP, now this is CVP is driving the cardiac function curve, where cardiac output was driving the vascular function curve. Does that make sense? Which, there's cause and effect. And so if you give somebody more volume in their heart, it kicks harder. That's the cardiac function curve. In reality, these things all work together, and we'll put them both together in a minute. But to study them, we like to isolate them and manipulate them and then understand them. So this is just what you've heard before. If I keep giving you more volume, I don't always get more cardiac output. There's a point of diminishing return where the Starling curve drops away. And this usually ends up in the area where we start having peripheral edema or pulmonary edema. In this case, it's the CVP, so this would be peripheral edema. But if I said I could put wedge PCW on this graph, and it would also show us a Starling curve. And if I went too far on that, I'd get wet lungs. Okay. I could give you a positive inotrope and make your cardiac function curve work at the same CVP. I would get more cardiac output because I whipped your horses and I made your heart beat stronger by beta receptor stimulation. If you have heart failure, or if I gave you a beta blocker, something to depress your cardiac function, you would be at the same CVP, you'd be lower cardiac output. So that's just showing us we had the vascular function curve with high volume, low volume, and the cardiac function curve shows high contractility and low contractility. Now let's put them together. This is the coupling of the heart and the vascular system. So now we've got the vascular function curve on this graph, same graph, and then this line is the cardiac function curve. So this would represent, although I would like to have seen this up here where everything was normal, but this might be, well, this is where they cross is equilibrium, but I really don't like how this graph is drawn because equilibrium should be up here about 5 and about 3, but we'll get over that for now. So let's just say we start from this point. If we add volume, we're going to slide this volume curve up. Now that's a good happy equilibrium point. I like that. The cardiac output's 5 and the CVP's 4. This crossing point is where we're at right now on this patient. I like that. That's a happy place to be. That patient's in good shape. If I take them and give them diuretics, I shouldn't have because now the cardiac output fell, and that's not good. I can give you stimulation with epinephrine, or I can give you a cardiac depressant, or you might have heart failure, and this line will move. I give you volume, it goes up here. I take away volume, it goes down here. These crossover points is where the patient exists at this moment. Does that make sense to you guys? Okay. So this is like, okay, what if we want to manipulate this? So here we start at position 1, and I give the guy a bunch of saline. He goes up to here. And then he gets heart failure. Then he goes down to here. And then we give him some epinephrine. And he's going to go back up to here. And then we give him some diuresis, and he's going. So we're just playing around with this guy with all these manipulations, and they'll move around on this graph. So the doctors will try to find the right cardiac output and the right amount of filling pressures for your hearts to optimize your cardiac performance. If they keep giving you more volume, you're going to get more cardiac output, but at some point you're going to get wet lungs, and then they went too far. If their systolic pressure is too low, then maybe they gave you too much afterload reduction, too many nitrates, or maybe they gave you too much diuretics, so they got to undo that, give you some volume or stop the nitrates. So they kind of watch for these blood pressure and CVP to be in a happy place, and they'll manage you based on that. That's why we go in the cath lab and put a swan in their heart, and they say, what's the CVP and what's the wedge? Because that's the filling pressures of the left and right heart. It's a big deal. Then it's easy to get systolic blood pressure. You just get a cuff, but you got to get inside the heart to get those other things. And when someone's really sick, we'll leave a swan in them for days. We'll put it in their neck, in their IVC, in the superior vena cava through their right internal jugular, and we'll stitch it in, and we'll tell them not to play with it. I always do. I say, hey, see this? Tell the patient, see this? And I put the swan in front of their eyes, say, don't play with this. See all these valves and all these, don't mess with these or you can lose all your blood. See this balloon? Don't inflate that or you might plug up part of your lungs. They're like, oh, well, I would never touch all that. But I talk to them because I know if I was a patient, I would have. I would have been messing with those valves and I would have been doing stuff with it. So I'm always telling them, like, for that one person who's going to mess with it, leave it alone. And then, but the reason we put it in their neck is so they can sit up in bed and they can be comfortable. Yeah. Like when the dentist leaves, I'm always looking over on his tray, like all that stuff. Like, what is all that? But he always leaves it out of my reach. So I can't get it. They always leave the room. They numb you and say, we got to let that take effect. And they'll be there. It'll take 5 minutes and then they take off. Then you're like sitting there like, what am I going to do? You guys have the same experience I have, I'm sure. Okay, anyway. So there's a quiz. Cardiac output's 3 liters, wedge is 30. We give them, we already kind of got this. I'm going to skip past this. There's a lot of other stuff. So we're going to talk about cardiac, we're going to talk about heart failure, and that's reduced forward flow. We're going to get into the 8 failures, and we often think about increased preload. You have congestion, And we think about the LV is going to do something called remodeling with those new conditions. It tries to reshape itself to respond and compensate. We're going to talk about two kinds of compensation. One is hypertrophy under pressure overload situations, and the other is dilating and under a volume overload situation. And that's called remodeling. When the heart makes itself different, it changes its dimensions, either the wall thickness or the chamber dimensions. That's called remodeling. That's a term you'll hear about in medicine. It also increases its heart rate. If you have reduced stroke volume, one of the easy ways for your heart to make more cardiac output is simply raise the heart rate. So a lot of our patients will come to us with a resting heart rate of like 85, 90. And you think, oh my God, they're almost in tachycardia and they're just laying here. They haven't done any exercise. That's because their heart ejection fraction is like 20%. It's barely squeezing out. And so the heart rate has to go up. So that means they don't get a lot of rest time in between systole and diastole. Their diastole is short. That's when your coronary is perfused, you get a lot of oxygen. So it's a double-edged sword for these patients. So they're working harder and they get less oxygen, and it's not good. It becomes a spiral. And there's the sword. There's all this back and forth feedback loop. Your kidneys get involved with heart failure. They start saying, hey, I don't get a lot of flow. So they start releasing renin, which makes your blood pressure squeeze. It makes vascular constrictor drugs called with angiotensin converting enzymes in your lungs and renin from your kidneys. You make this angiotensin 2, and it's angiotensin converting enzymes from the lungs, renin from the kidneys, and it makes this high powerful vasoconstrictor. So your kidneys trigger this triple chemical reaction in your body with multiple organs involved to create a vasoconstrictor to raise your blood pressure. We're going to learn more about that in the final chapter, which is special circulations, which is going to be your watch the video on your own. But it's kind of interesting how the kidneys manipulate blood pressure. And then another thing that happens is aldosterone is released, and that creates sodium retention from your kidneys. So your kidneys are saying, man, I got a low pressure here and I don't like it. So I'm going to do something to get some fast blood pressure relief with this angiotensin 2 mechanism. I'm going to get the blood pressure to vasoconstrict. So that gets it a fast response because the kidneys want their flow. But it also releases this aldosterone, which makes the body hold on to sodium, which changes the ionic gradient of your blood, and it makes the volume stay in the vascular system. Remember we were talking about albumin and how that would keep the oncotic pressure, would keep volume in? Sodium would do the same. If you put a bunch of sodium in your blood, it'll make your pressure rise. That's why they say don't eat so much salt if you have hypertension, because the sodium in your vascular system wants to pull fluid to balance out the equilibrium, and it makes your volume of your vascular system rise, sodium. So the heart knows that. So it says, hey, I'll just keep on to that sodium, and we'll get more volume in here, and I'll get that stretch for my cardiac function curve, my Starling curve, and I'll make myself happy that way. So this is what your heart does. The brain's involved too, all the sympathetic tones. And so it's kind of cool how your body, all the heart rate mechanisms. All right. Laplace's law has something to do with the dimensions of the chamber. And there's a formula. I don't bother memorizing the formula, but it's basically 2 times h is the thickness and p is the radius. So the tension in the chamber is a function of the radius, how big is the chamber, and also the wall thickness. And if you have long-standing hypertension, that will make your body make the wall thickness rise. It'll become hypertrophied. And I think we have, there we go, thicker wall. So then you're going to have higher tension in there. It takes more oxygen to run a hypertrophic ventricle because it's got more muscle. It's like it takes more gas to run a V12 Ferrari than it does to run a 4-cylinder Fiat 500, Cinquecento. And they're both Italian. They're both fine Italian cars, but we all know which one we'd rather drive. We all know which one we'd want to fill up at the gas station too. So you got to balance out your life needs and your life opportunities.
So on left ventricular hypertrophy is like a symptom often shown as a for that one.
So what we're getting, Betsy's asking, what is a symptom of LV hypertrophy? Hypertension, we don't feel it. It's the silent killer. So there really isn't a symptom of that. You don't feel it. It's like you're driving your car down the road, instead of being in highway gear, you accidentally left, instead of drive, you actually left it in 2 on the automatic. And now that instead of the RPMs being 3,000 when you're driving 60 miles an hour, the RPMs are 5,000. Your engine will drive all the way to Seattle at 5,000 RPM. You'll use up your oil and heat your engine up, and it won't be fuel efficient, and it'll wear your engine out. That's kind of like what happens when your body's running into hypertension. It's like high RPMs. It can run like that for a long time, but it won't last as long. So you really don't feel this. Sometimes people will feel ischemia if their heart is asking for so much oxygen and the coronaries can't keep up with it. Then they start having a little bit of chest pain, but not so much shortness of breath. That happens more when you're dilated, which is the next example. So here's a guy that's got a dilated cardiomyopathy. Maybe he had an aortic insufficiency, his LV's pumping high volume, he has mitral regurgitation, or he's had so many heart attacks that the walls are just giving way and now they're all dilated out. There's also viruses you can get that attack all of your muscle, and they're not able to contract, so you end up with big dilated, saggy, baggy heart. And there you have increased radius, which increases the wall tension. Now that takes more oxygen to pump too. That's my example, like in hemodynamics, of if you're lifting weight from here with a stretch was not very far from my biceps, easy. I'm lifting the same weight, starting way down here, I'm all stretched out, harder, takes more oxygen. So that's the failing dilated heart. That's the worst thing you can do to a heart, is dilate it. Then they fail quicker. If they become hypertrophied, they can kind of keep up with that for quite a while. In fact, if you have long-standing hypertension and you don't treat it, eventually the body can no longer overcome that with hypertrophy, and it starts to fail and dilate. So that's one of the things in echo you guys will be watching that over. You'll be doing sequential echoes. If somebody's got systemic hypertension and we're measuring their LV wall diameter, the doctor will manage their blood pressure, and you'll take sequential echoes. And what you're watching for is that the wall thickness will begin to drop as the heart unremodels. It remodels back to normal. If you start seeing the wall thickness is intact and the chamber dimensions are rising, that heart is failing, and the doctor will do something more aggressive. I was involved with a study, the doctor from Harvard, when I was working echoes in Seattle, and this is what we were studying: how the heart responds. When does the hypertrophic heart begin to fail, and how does it fail? It starts to dilate.
Darren?
Oh, go ahead.
Did I just hear you say that you can remodel the backwards way from left ventricular hypertrophy?
Sure. And if you take the pressure away, it can go back to normal, you bet.
And that's why they say diet and exercise?
Yeah, diet and exercise. And then statins, if you have atherosclerosis in your coronaries and you take a good load of statins and you exercise and manage your diet, you can minimize the percent stenosis of the coronary arteries or the carotids or anywhere. It starves that lipid pool. It basically kind of shrinks the lipid pool that's inside the plaque. So yeah, they can go back to normal. Well, they can head towards normal, let's say. All right, that's enough about that. But the worst thing you can do to destroy a heart is to stretch it out. That's the fastest way to ruin a heart, is to stretch it out.
Darren, quick question. So you're saying that if there's a larger radius, that there's both dilation and hypertension?
So the Laplace's law has to do with the radius and the wall thickness. Mm-hmm. So I put the hypertension and dilation together in the sign of long-standing hypertension will give you hypertrophy, right? Everybody that's pretty easy to understand.
Yeah. That
if you make the muscle work harder, it's going to get thicker. We all do that. If we go to the gym, you start working out, you're going to bulk up. But for hearts, if you keep giving them a load of pressure, at some point they can't keep compensating, and then they begin to dilate. And that's when they begin to fail.
Okay.
That's what I meant to say. That was my message. Now we'll get into these 8 kinds of heart failure. So we all know about Poor cardiac performance leads to increased LVEDP, and the pressure can back up in the lungs, and you can get edema. And it looks like this. See this X-ray? See how modelly this lung is? It's supposed to be dark like that, just air. All this is fluid, and that's the wet lungs. And the wet pools at the base, like that, and these gravity-dependent areas get the wet first, because like, where does the water go in your house if you have a water leak? It goes into your basement, not in your attic. And so there's the attic of your lungs if you're sitting up. And that's part of why a lot of people want to sit up, because they want to get more open air space. They don't want to lay down and drown in their own fluid. They want to sit up and kind of let gravity drain a little bit. And a lot of people with wet lungs, they'll even do what's called pursed lip breathing. They'll go like, and they're basically adding pressure to their lungs to push that fluid, to make the air pressure in the sac. I think I have a picture of the sac. They do this pursed lip breathing naturally to try to stop their drowning. And so when they add air pressure in here by pursed lip breathing, which is, you'll see a patient that's really in trouble, they start breathing like that, and now they're trying to increase this pressure and to push this fluid back into the vascular space. We can do that with a ventilator too. If you really get into trouble, we can add pressure to your lungs and push the fluid out of your lungs. That's a mechanism we do. Positive airway pressure. We actually add pressure to your lungs with a ventilator. But here's a patient that's got a congested heart. That's what it looks like on chest X-ray. The size of the heart should be less than half of the diameter of the chest. So let's back up. Let me take my little measurement here. So if I take this, the diameter of the heart, it should be less than half of the diameter of the chest. And if it's greater than that, that's called cardiomegaly, or a large heart, the dilated heart. So this one's right at about half. So it's getting on the edge of being too big. But sometimes you'll see a heart where the boundary of it's like way over here, and the diameter of the heart is more than half of the diameter of the chest. That's a large heart, and that's dilated cardiomyopathy, heart failure. Radiologist sees wet lungs, big heart, heart failure. Okay, now we're going to look at all these. There's eight heart failure scenarios: left heart failure versus right heart failure. We've addressed that pretty thoroughly in hemodynamics. That's your more typical way of thinking about heart failure. But there's also, you could break it down into chronic, which has been there a long time, versus acute, which is new. Or you could think about heart failure and how the body looks at it from the front end to the back end, which is more obscure, and we'll talk about that in a minute. But then this is what Dr. Limegrubber talked about: systolic heart failure versus diastolic heart failure. So this is 8 ways at looking at heart failure. And we'll talk about each of them. Right heart failure is when maybe you had the right coronary artery got knocked out and you lost your acute marginal branches and the walls of the right ventricle died. And now your right heart doesn't pump and it dilates out, and your RVEDP rises and your CVP rises. And it could also have happened because you had lung disease, some kind of fibrotic lung disease, and your pulmonary blood pressure is high and your right ventricle is pushing against high pressure and it fails. Can't keep up with it. Could be from smoking or working around asbestos, or working around, you see these guys in these car shops on these, I watch these cable shows, and these guys are grinding down all this fiberglass. That's like just like tiny little daggers into their lungs. They're going to be in trouble when they're 65, 70. They're making some beautiful cars, but they're going to pay for it. So stay away from fiberglass dust. Like, don't have the job as the insulation installer. Don't do it. It's not worth it. Left heart failure is if you have LV dysfunction from MIs, or you had long-standing systemic hypertension, or aortic insufficiency, or mitral insufficiency, and your pressure backs up in your lungs and pulmonary edema. So that's our typical right heart failure, left heart failure. Now let's talk about acute heart failure. This is saying, well, what would make your heart fail all of a sudden? Well, a STEMI would. you knocked out a wall because you lost a coronary artery. That would give you heart failure from you didn't have it this morning and you had a STEMI this afternoon, and tonight you have a heart failure. That's acute. It just came on. Chronic would be more like this long-standing hypertension or aortic stenosis, or you got some kind of viral infection and you got a disease of your whole muscle, cardiomyopathy. There's a lot of bugs down in Central America that carry these parasites and they attack your heart. The kissing bug, and they're in Brazil, and I had a chance to go to Brazil and I was looking out for these bugs. They're called the assassin bug. There's a picture of one in the room back there above that pencil sharpener. And they're around. They come out at night. I didn't get bit by one apparently, but I was worried about it. And you know, you don't go swimming in the water in the Amazon because there's piranhas, and you don't pee when you're in the water because there's little things that'll swim up your urethra with little reverse forward hooks. Yeah, there's all fleur-de-lance, really dangerous snakes, and they'll chase you and bite you again. There's really a lot of dangerous things in the jungle, but it's kind of makes it more of an adventure to go there. Once when I was in Thailand, I walked 40 minutes off into the jungle to sit by myself on this private beach. I was an hour from civilization on this. I had rented this fantail boat to this private beach on this island under the advice of a friend. And I went in the jungle for 40 minutes just to see what was what and see what I would see for animals. And I kind of wanted to see, have you ever heard this story? Because I don't like telling me. My goal was, I didn't want to see a tiger because they live there too. And I was okay if I saw an elephant, and I kind of wanted to see a monkey. But what I really wanted to see was a king cobra, because they live there, 18-foot long serpent. They can stand up like 3-4 feet. I wanted to see a king cobra. And so I'm in there and I'm like in hunt mode. I'm 40 minutes sitting there, and I heard some rustling in the branches, in the bushes, and the leaves. And so I thought, oh, that's a huge snake. It was huge, something moving under the leaves. And I ended up bailing out. I ran down to the beach. I got out of the forest. So I don't even know what that was. It freaked me out. Could have been the king cobra, but it's kind of coming towards me and I didn't like it. All right, so forward heart failure is when your kidneys say, hold on to the sodium. That's forward heart failure. Reverse heart failure is something you already know about, and that's just when the fluid backs up into your ankles, pulmonary pitting edema in your ankles, or pulmonary congestion. That's reverse heart failure. So some of these kind of cross over each other. So forward is the sodium retention, reverse is the dam effector, congestion in the veins. Systolic is when your LV can't generate the force. Maybe you lost some coronary arteries. Diastolic is when your heart can't relax. Maybe you had that infiltrative, remember that disease, that restrictive cardiomyopathy, where you had the infiltrative disease where the muscle can't relax? That's why you had the high pressures and the square roots. That would be like a diastolic disease. Okay, these are 3 drugs that you can use to treat heart failure. Digitalis, diuretics, and dilators. Increase contractility, take the wetness off, get rid of the volume, and then drop the afterload with the dilators, make the heart easier to pump. So that's Wes's, the 3 Ds. And then all this, New York heart failure. There's 1 through 4 relationship. We had to do this in homework in the first quarter. You don't want heart failure, so 1 is good. 1 is no heart failure. 4 is such severe heart failure that these people can't even get up and carry on with life. They're cardiac cripples. They can't even operate in society. If you have heart failure 2, you could still go to work. 3, you're going to be limited, nothing physical. And 4, you're stuck at home. Just normal body functions gives you shortness of breath. You can barely function. This is heart rate response and cardiac output. And so there's a happy zone for your heart rate, pretty much between 1 and 200. You know, we rest at 50. And if you get increased heart rate for exercise, you get a huge rise in cardiac output. At 100, you're still getting a rise. At 150, you're still getting a rise. But you start going up close to 200, you're going to start going so fast the heart can't fill. And pretty much anybody at a heart rate of 250, your heart's going so fast you can't get cardiac output. So there's this sweet spot for your heart rate. When we're trying to put a valve in somebody's aortic valve with a balloon, we put a pacer in you. We pace you at 250 to knock out your cardiac output. And we inflate our balloon and puts the stent inside the new valve in your aorta. And then we blow the balloon down, turn off the pacer, and then we see the hemodynamics. Like if you had aortic stenosis and we're putting in a new aortic valve in you. We do that in the cath lab. If we didn't do that, the stent with the valve would be like a watermelon seed, and we try to put it in your aorta. If you pinch a watermelon seed, it spits out. So if we left your heart pumping at normal rate and we try to put something in your aorta and plug it, it's going to get spit out of there and not be where we want it. What if the stent got put up where your coronary ostium was, and now we blocked your coronary artery with our new aortic valve? Catastrophic failure of procedure. So we don't do it that way. Okay, let's talk about venous pooling. So if you stand up, the surface veins collapse because they're not rigid, but the legs that are dependent, the veins that are down your legs, they swell up because they're compliant 20 times. They'll swell up. So when you're standing, your leg veins are all stretched out, and your up in your neck veins will be all collapsed, the surface ones. This is just what happens. If you take your hand and put it down below, I can see all the veins in my hand. If I put it above my head, they disappear. It's not a big magic trick. It's just gravity. That's what's going on. Now, the deep central veins, they stay open because they have connective tissues holding them together. But this is more about the surface veins. If you have venous pooling in your ankles, you could have pitting edema. Now, and that's the sign of right heart failure. Your valves, if you have a job where you stand a lot, you can cause valve damage and you can end up with varicosities. Look at the venous pressure when I'm standing. It's 80 millimeters of mercury. You start walking, it drops down to 20. That's because the muscles are pumping the blood, and these one-way valves in your veins are moving the blood up against gravity up to your chest. So that's where the muscles in your legs help bring the venous blood back up to your core when you're moving. People stand in a wedding and they wait for the preacher to finish his speech, and they pass out because all the blood pooled in their veins. Or soldiers at attention on a hot tarmac waiting for the general to arrive, they pass out because all the blood pools in their veins. So they don't want you moving around, but if you were up and down on your balls of your feet and just moving your legs a little bit, that would bring that blood back up to your core. So if you're standing in a wedding and you start getting lightheaded, start doing the Rodney Dangerfield to start moving around, or maybe sit down. This is what happens when we take this is inspiration effect. You already know that when you inspire, you get a wave. It causes a negative wave. This doesn't, here it is. It causes a negative wave of pressure. We already know that one. This one's reversed. This is something new. So if I put a machine in you and make you breathe by forcing air into you like a ventilator, everything's reversed. So that increased pressure in your lungs, which causes inspiration with a ventilator, will actually raise the pressure. So when you take a breath in normally, your diaphragm goes down and your venous pressures go down. But if I make a machine breathe for you, when the diaphragm goes down, that was because pressures were pushed in there, not a vacuum. It's reversed. So instead of dropping pressures, you get elevated pressures like that. So everything, all the physiology of the venous return in your chest is reversed when you're on artificial ventilation. And it's simple. It's just because instead of a vacuum to bring air in, we're adding pressure because you are no longer breathing for yourself. When we do that, we can do that to help increase the pressure in your lungs to push the fluid out of your wet alveolar sacs, and that can minimize the pulmonary edema. And that's called positive airway pressure, PAP. We call it PAP. And when someone's being ventilated, we can add pressure to push fluid out of their lungs. And that's really the main thing about this unit. That was it. These are some questions Wes was going to ask, but we're running out of time. It is 9:20 exactly, and we are exactly at the end of our time. But I do have time for one more question or two, but we won't go till 9:30 and push everybody into the next class. That's not cool. Questions? Comments? cardiac function curve, vascular function curve, the 8 kinds of heart failure, gravity, respiration, those kind of things. I already wrote the test. You guys did really good on last week's test. It was a 95% class average, highest of the quarter. Good job, everybody. All right. Yeah. Is Tina coming in today? So I'll just leave the, she's not doing a lecture today. So goodbye to you guys for echo and vascular. And for invasives,